Uh, Today, we are going to discuss a very important and I think most commonly managed symptom in most of our settings, management of nausea and vomiting, with a special focus on refractory nausea and vomiting. We have two faculty for today's session. One faculty is Dr. Sonal Admain. She's from MD Anderson Cancer Center. She's assistant professor in Division of Palliative Integrative Rehabilitation Medicine in MD Anderson Cancer Center. And second faculty, you are all familiar with Dr. Naveen Salins. And I'm so glad to introduce him because I had a chance to work with him for some time, and I'm sure that he's one of the best teachers who taught us so many things. So I'm really, and I still remember it was from Dr. Naveen. I first heard a session on nausea and vomiting, and I still remember every single part of it. So Dr. Naveen is heading the Department of Palliative Medicine and Supportive Care at KMC Manipal, and he's done his MD General Medicine from Manipal, and he has a PhD in Palliative Medicine from Lancaster University, and so many other degrees. I'm not reading everything, but I am sure that most of you are very familiar with Dr. Naveen. Thank you so much, both of you, for agreeing for um, sharing your knowledge with this group. So the first part, Dr. Naveen will be talking mostly about recent updates on guidelines on management of nausea and vomiting. And second part, Dr. Admin will be talking more about refractory nausea and vomiting. Thank you so much, Dr. Naveen and Dr. Admin. Over to you.
Thank you so much, Dr. Sridevi, for a very, very generous introduction. I don't think I deserve that. So I will start sharing my screen. Is the slides visible?
Yes, sir, it is visible.
Am I clearly audible to everyone?
Yes, sir, you are.
Okay. So as Dr. Sridevi has mentioned, in the first part, I would look at some review of evidence on nausea and vomiting. And what I have been told that most of the participants are familiar with the nausea and vomiting, and they're familiar with the pathophysiology and familiar with the management of nausea and vomiting. So I'm taking a step higher from there, and I'm looking at what is the evidence that exists. And when I'm looking at nausea and vomiting, I have restricted my presentation only to a palliative care setting. Nausea and vomiting, when you search the literature, it's very vast in cancer and non-cancer. And in cancer, there's a huge literature on chemotherapy-induced nausea and vomiting or radiotherapy-induced nausea and vomiting. I haven't touched that part. I've restricted myself to a very small section that is in a palliative care setting, what evidence exists. And also, I looked evidence for only last 10 years. I haven't looked before 10 years. So from 2012 to 2022, what has been the evidence and how does it probably would inform our practice? And uh, if we look at the search, I use the Scopus database to search the literature. And I did this search on 15/8/2022. Unless there is a new paper that has come in last 2 days, this is as current as it can get. So when I searched for the last 10 years, using nausea, vomiting, and palliative as the keyword search, limiting myself for the last 10 years, there were only 42 hits. So you imagine the numbers are quite less, the evidence is quite less. And I am not discussing any case reports. There are a lot of opinion papers written on nausea and vomiting or unsystematic review. Somebody has just written a review article and editorials. So when I say evidence, I have excluded all these things, case reports, unsystematic review, opinion papers, and editorials. And I purely looked into what exists beyond this. And the numbers becomes much smaller than 42. So it's also says that there's not much work done in last 10 years, especially looking at palliative care in nausea and nausea and vomiting in a palliative care setting. However, let's look into what work has been done. So there are three parts to my presentation. So I looked at various pharmacotherapies for nausea and vomiting in the last 10 years, some of the non-pharmacological management of nausea and vomiting in the last 10 years, and some of the evidence and guidelines that are there regarding nausea and vomiting. So these are the parts of my presentation. I will go very slow. The slides might look busy, but I will go very slow and try to explain to you as much as possible. Now, this was a 2021 paper which looked at olanzapine for management of nausea and vomiting. So all my tables has three parts. First part talks about the intervention. Second part is a reference. I will share my slides with the organizers, so it is free for dissemination. And the third part, I am going to describe few key findings from the paper, which also includes the methodology, the intervention, and the population. So let's look at olanzapine. So olanzapine is predominantly used in refractory nausea and vomiting. And there was a prospective observational study. The good thing about this paper was it was multi-center. That means in many centers where palliative care services were offered, this study was conducted. And they used low dose olanzapine as the intervention, that is only 5 milligram or less. And the outcome of this study was that it showed significant reduction in the nausea on a numerical rating scale. So there was a numerical rating scale, which is 0 to 10 scale, and patients were asked to grade their nausea. And you can see from an average of 6 point around 6 to it has fallen to around 2. So there was a significant reduction in nausea in numerical rating scale. There were decrease in the vomiting episodes. The only downside was 18% of them who took olanzapine had increased drowsiness. So it's a good evidence. However, it is a single arm study. It's a non-randomized population. So it was used for a very short period of time. We don't know what is the benefit long term. So there is still scope to expand this study, and it is published in a good journal, which is Supportive Care in Cancer. There is another paper which looked at olanzapine only, slightly older, from 2021, going back to 2016. Here it was a case series. So again, it was done in different centers. So the good part is it was done at different centers. And here, the dose of olanzapine was almost very similar. They used 5 milligram of olanzapine bedtime. Again, it's mainly in the refractory setting I'm talking about. Here, the intervention was a varied intervention. In some centers, they used as short as 3 days. In some centers, they used for a longer period of time. So the response was good. There was a good relief of nausea and vomiting, and the side effect profile was acceptable. However, again, like the previous study, it was a single arm, non-randomized study, predominantly the evidence from a case series. So the third study, which is there, which is based on levomepramazine. Levomepramazine, unfortunately, is very hard to find in India. It is a very commonly used drug in the Western setting. I had used this quite a bit in my practice in another country, and they compared levomepramazine as an antiemetic with haloperidol. So we all know haloperidol is a common drug that what we use in nausea and vomiting. The good part of the study was it was a head-to-head randomized controlled trial. So the population in which this was studied was patients with advanced cancer. And what the study showed is that the haloperidol versus levomepramazine. Levomepramazine was by no means superior to haloperidol. The outcomes in terms of reduction in nausea or vomiting episodes was the same. So haloperidol is a time-tested drug, and if you look at on the column on the left, I purposefully put the receptors it blocks. It blocks all the dopamine receptors, the serotonin receptor, histamine, muscarinic, alpha adrenergic, you know, even the receptors and its subtypes. Even then, haloperidol is predominantly on the D2 receptor antagonist, isn't it? Levomepramazine was not found superior and was published in British Medical Journal Open in 2019. So we can still confidently use haloperidol. So there was another study which was on haloperidol published in 2018 for management of nausea and vomiting. It was published in a good journal, this Journal of Palliative Medicine. It's a quartile 1 journal. And it was a prospective multi-center study like previous studies. Uh, it was it was conducted at many centers and conducted in patients admitted to a palliative care unit. And each unit had used different doses, but the drug was the same. The dosages were different across the centers. 79% had good or complete resolution of nausea and vomiting, which is an excellent thing. Haloperidol is a very cost-effective drug. So in a patient with a refractory vomiting, it was worked very well. The only downside of this was 40% of them had constipation, 21% of them had dry mouth, and 19% of them had increased drowsiness. However, it was used as a mainly as a short-term agent, and it was a non-randomized study. But if you look at the previous study, which was a randomized control study, which compared levomepramazine with haloperidol, and haloperidol was not found inferior, or levomepramazine was not found superior. So haloperidol still has got a lot of evidence coming in. It's a 2018 publication. Now going from pharmacotherapy slightly to a non-pharmacological management. And one of the thing that looked at was aromatherapy. And aromatherapy for nausea and vomiting. And it was a prospective longitudinal study. And for aromatherapy, they had used lemon oil pads. So I actually had to Google and see what a lemon oil pad is. So you get this lemon oil, and it's used on a pad which is able to soak that oil, and the patients are asked to sniff that pad. And lemon traditionally is known to help patients with nausea, and this lemon oil pad, which was used in a prospective longitudinal single arm study in patients with advanced cancer. And the good thing that came out of this is 73% who had no relief with first and second line antiemetics had good relief, which is again coming in as an agent for refractory nausea and vomiting. So 73% is a big number, isn't it? So those who had no relief with the first and second line antiemetics had good relief. However, it is a single arm study. Probably we need a randomized control trial. And this is very recent evidence. It's published in 2022 and it's published in a top journal called Cancers. And so it's a very, very recent evidence. Probably a lot of work could be done on this further, maybe a randomized control trial or something like that to further know more about it. Now, there was another aromatherapy which was used to see in children whether aromatherapy helps in nausea and vomiting. So this was a pilot randomized control trial. So before a main randomized control trial is conducted, a pilot randomized control trial is usually conducted to know whether a trial is feasible or not. And they have used a symptom specific aromatherapy scent. So they haven't mentioned what it is, but they mentioned it as symptom specific aromatherapy scent. And in children, it improved nausea and vomiting. So the scale used in children is called as the Baxter Retching Faces Scale. You might all must be familiar with Wong-Baker Faces Scale, no? That is used for pain. So for nausea, the scale used in children is Baxter Retching Faces Scale. So on the Baxter Retching Faces Scale, there was an improvement in nausea by 3 points. However, the downside of this study was that a lot of children had allergy to this aromatherapy. Some people also had some bronchospasm. So again, needs more evaluation. It's a 2020 study published in Palliative and Supportive Care Journal. Now, looking at another very interesting study, I felt again very recent, 2022, published in American Journal of Hospice and Palliative Medicine. They used a very simple technique called as olfactory distraction. So they haven't used an aromatherapy like how the previous two studies, like lemon oil pad or another unknown aromatherapy. They use the alcohol swab, which all of you know, using a spirit swab. And they found that if you distract the patient by asking them to sniff the alcohol swab, it reduced nausea and vomiting. However, I would take this study with a pinch of salt because this is a case series, a very, very small case series. This is not a prospective longitudinal study, not an observational study, not an RCT. It's a short case series. So what it just says that there is this evidence that is available for somebody to study in detail, but I would not take it as an evidence for use. Now, there was another study, again in a non-pharmacological treatment on acupressure. You know, acupuncture and acupressure are tried in patients with refractory nausea and vomiting. And this was another 2022 study, which was published in a good journal again, BMJ Supportive and Palliative Care, which is an excellent journal, which showed that acupressure wristbands. So they used a normal wristband with another wristband which had an acupressure property, and there was no difference. The acupressure did not improve the VAS stands for visual analog scores for nausea and vomiting. It did not reduce the antiemetic dose, neither it prevented escalation of antiemetics. So acupressure, so it was a negative trial which was published in 22, where acupressure did not improve the nausea in terms of VAS scores, that is visual analog score, did not improve the need for antiemetics or did not stop escalation of antiemetics. There was another paper again on acupressure for management of nausea and vomiting, which was published in 2021, which was a prospective longitudinal study in patients admitted to a palliative care unit. And again, the intervention that was used was acupressure. The study showed was acupressure was feasible and safe. However, if you look at the benefit of acupressure, there was no benefit in the patients who were on acupressure. Now, I looked at some of the systematic review that was published, starting from main studies to systematic review. And this was one systematic review. This is an older paper, which was published in 2012. Still, I'm bringing this paper because there was after 2012, there is no systematic review as good as this has come. So somebody could, if some interest in systematic review, this is a topic people could do, where they looked at many things together: 5-HT3 receptor antagonists, steroids, antihistaminics, anticholinergics, somatostatin analogs, benzodiazepines, cannabinoids. So everything together in the management of nausea and vomiting. And it looked at papers from 1966 to 2011. So many years papers were taken, and they looked at 75 studies. And So they looked at 75 studies in this review. So some of the thing, although this evidence is old, almost old as 10 years, so 5-HT3 antagonists were only recommended when metoclopramide or neuroleptics like haloperidol or olanzapine is not able to control nausea and vomiting. Steroids will work not de novo or just by itself, but along with antiemetics, it can help. Cannabinoids are only second line agents. And if there is a malignant bowel obstruction causing nausea and vomiting, octreotide is superior to hyoscine, and there was insufficient data regarding antihistamines and benzodiazepines. However, I would like to still emphasize that this is a 10-year-old review. Probably we need a better review at 2022 to see what has happened from 2012 to 22. But still, this is the best systematic review that was there. Now, I looked at guidelines from India and international. What are those guidelines that are available? Can those guidelines help us in our practice towards improving nausea and vomiting? So there was this guidelines, prominent guidelines from BC Center, Canada, NCG guidelines from India, which you can find in TMC website, Western Australian guidelines from Australia, and NHS guidelines from UK. All these guidelines were poorly written. So, if you want to prepare a guidelines, there is a methodology to prepare guidelines, and there is a scoring system, how evidence is collected, how evidence is collated, and it is graded, and levels of evidence is provided. And all these guidelines has to be evidence linked. You can't just tell that you use this first, you use this later, or you could use this, or you could use. They are all our opinions. Opinions have no role in guidelines. So all these guidelines that are there are predominantly opinions of the authors, and there is a very limited link to the evidence. So what is to be followed? So this probably has are better guidelines when I looked at. So two guidelines that what I felt was most useful was the Scottish palliative care guidelines. So I provided the link here. As I told earlier, I'm going to share the presentation so you could go into the link. So this Scottish palliative care guidelines provides a good clinical approach on how to manage nausea and vomiting, and it has an etiology based management. So if this is what is causing nausea in a palliative care setting, you could use this, and it could justifies the choice of antiemetics, although the direct evidence link is missing. So the best guidelines that I could get hold of when I looked at everything is from Up to Date. Now, the Up to Date guidelines is prepared by the MD Anderson Center. So that's who is going to speak next. And Dr. Eduardo Bruvera is the editor of these guidelines. I felt this is the best guidelines for managing nausea and vomiting. Clearly etiology-based approach, clearly in a palliative care setting. It is very practical and it is very evidence-linked, and it links to the most recent evidence. So this is my recommendation. If I am going to follow something for my patient, probably I'm going to access this as the guidelines when I'm practicing. So in conclusion of my talk, what did I find when I looked at everything? I found there was sparing evidence for nausea and vomiting pharmacotherapy. It was very restricted to a very handful of drugs: haloperidol, levomepramazine, olanzapine. That's it. So if you look at the pace with which oncology is producing drugs, we haven't actually produced any drugs to help nausea and vomiting. There are few drugs in chemotherapy induced nausea and vomiting, but if you look at palliative care setting, we are just repurposing the older drugs. So no new drugs developed for management of nausea. So this is a matter of huge concern. We have to see. And if you look at non-pharmacological management, in the last 10 years, there's only evidence for aromatherapy. which has shown benefit in management of nausea and vomiting. Other non-pharmacological management, even when I've looked at Cochrane, the evidence is very minimal. So in my talk today, I had predominantly touched at evidence rather than giving my own opinion. It's to see what exists, and for us to stand shoulder to shoulder with another specialty who talks predominantly an evidence-based medicine, we probably have to mm, provide more evidence, create more studies. That's very important. Otherwise, we are still using the same things for our patients. And that's all I want to talk today on evidence regarding nausea and vomiting. And I look forward to the next speaker speaking on uh, refractory nausea and vomiting.
Thank you so much, Dr. Naveen. There are a few, one or two questions there. I think we'll take it up together after Dr. Admin's presentation.
Okay.
And a lot of thanks also have come for the evidence-based approach and very clear presentation. So we'll take up the question together after Dr. Admin's presentation.
Sure.
Thank you so much.
Thank you. Thank you.
Dr. Admin.
Hi, good morning.
Hi, Dr. Admin. I think, yeah, you can go ahead. Maybe you can speak a little louder. So that,
yes, is everyone able to hear me?
yes, yes.
Okay. I'll try to speak a little louder, but just interrupt me if you cannot hear me. So,
yeah, it's a little low. If you can speak a little louder, that will be good.
Yeah, definitely.
Thank you.
Is that better?
Yes, yes, please.
Okay, excellent. So let me share my screen and see if you're able to look at the presentation. Okay. And is everybody able to see my screen now?
Yes,
Yes,
Dr.
yes, we can.
Yeah, wonderful. So, hi everyone. My name is Sonal Admane. I'm one of the assistant professors at University of Texas MD Anderson Cancer Center. And I would just like to start by saying Dr. Saden's presentation was extraordinary. I learned so many new things, and I can see how his introduction is very well deserved. So I think he's laid a very good background for this presentation. So I was told to do a case-based presentation, and I'm hoping that as we go on with the cases, we can really, go deeper into how we are approaching management of refractory nausea and vomiting. I think one of the things Dr. Salins mentioned is that most of the evidence we have is for cancer, and nausea and vomiting that's seen in patients with cancer and advanced cancer. So most of my cases are going to be in that area. Also, feel free to use the chat box because we want to make this interactive and see what the audience, how the audience approaches the management of cases, and then we can go forward. So, to begin with, let's look at this picture, and I think I really like to look at it before beginning to address any symptom of nausea, because we really need to keep in mind that the causes are multifactorial, and you really have to go investigating nausea and vomiting in a very multifactorial way before you use a particular medication. So targeting any of these is as important as starting a medication. Moving on, really approach to nausea and vomiting consists of two ways, and none is superior to the other. One is the mechanistic approach, in which we really choose the drug based on the understanding of the pathway, and it's very receptor driven. Dr. Salins mentioned most of these receptors in his presentation. The other is the empirical approach, in which the physician chooses the drug based on their preference and anecdotal evidence, and how the drugs work in their patient population. For our practice, we really prefer the mechanistic approach. The empirical approach is not wrong, because, as you heard from Dr. Salins, we're using the same medications. We're using the old medications. So if you choose a combination of medication, they are likely to work. But then, if you are met with a patient who has refractory nausea and vomiting, you will have to choose a broader spectrum agent and then look at underlying causes. So, as I said, our practice usually is based on the mechanistic approach, which is the receptor driven approach. And so the major receptors and transmitters which are involved are these, of which the ones that we usually target are the dopamine, serotonin, and the acetylcholine receptors. So I really like this table, which shows the affinity of the most commonly used antiemetic agents for treating nausea and vomiting in patients. And as you can see, something like olanzapine, which is now slowly emerging as a very potent antiemetic medication, has action against multiple different receptors, and so does metoclopramide, especially at higher doses, when it also starts acting on the serotonin receptors. So when you're treating refractory nausea and vomiting, we recommend you use a combination of medications which is targeting all receptors that are involved in the nausea and MSS pathway. So really the goals of assessment are: one, clarify what the patient is reporting, attempt to determine etiology, and the various receptors that may be involved, and really take a very good history of all the other symptoms and medicines, and underlying metabolic factors which may be impacting the patient's symptom, and then choose an appropriate therapy. So let's start with our first case, and I would request the audience to put their answers in the chat box so I can take a look at it. So the first case is Mr. MM. He's a 60-year-old gentleman who has stage 4 colon cancer and is seen in your clinic. He is currently receiving chemotherapy, also on extended release and short-acting opioids, which he takes for his cancer pain, and he has a 2-week history of nausea. He is on ondansetron 8 milligrams 3 times a day without much benefit. He also recently started taking prochlorperazine 10 milligrams. He's tried it for 2 doses, but he still continues to complain of nausea and vomiting. So at this point, what additional information would you like to gather on this case? And I would appreciate if you can put your comments in the chat box. I'll give a few
There is a
more
comment.
seconds.
There are chats coming up. Bowel habit.
Wonderful.
Does he has gastritis, fecal impaction,
Excellent.
liver mets? These are the questions people have asked.
And I think you all nailed it, because I think that's the first thing we look at when you're looking at a patient who's on opioids, who has a GI cancer. That are the bowels moving? Does the patient have refractory constipation? And if so, if you get a positive history, really the approach is first to treat the underlying symptom. Next, what is the etiology of nausea in this case? And I'm looking at the answers in the chat, and I think everyone had excellent answers. And gastritis, yes, definitely. That's something we need to rule out, because patients may say nausea, but they actually mean gastritis. Okay. Some of the other things to consider in this case are really what receptors are we targeting when we are managing nausea. So the common ones are dopamine and muscarinic receptors. So I see morphine in the chat box, and I just wanted to know, are you saying morphine is the etiology? Okay. And how do we approach the treatment in this patient? So I think almost everybody in the audience got it right. So impaired gastric emptying and opioid-induced bowel disease is actually one of the most commonly seen etiologies in patients with cancer who are on opioids and even advanced cancer. And they usually present with early satiety, nausea, postprandial fullness, abdominal pain. Opioids, by causing opioid-induced bowel disease, have a direct effect on the chemoreceptor trigger zone. They also enhance vestibular sensitivity and cause delayed gastric emptying. So really, in our practice, our drug of choice is metoclopramide, an older drug, but still extremely effective. It is cost effective. It has a good broader type of action on the receptors. It has prokinetic activity, which is very useful in patients with delayed gastric emptying. Usually the recommended dose that we use in our population is 10 milligrams every 4 to 6 hours. We reduce this dose by 50% in elderly and those with renal impairment. Metoclopramide is also a unique antiemetic because it can really be given by different routes, by oral, by sub-Q, IV, rectal, and even nasal spray. So we also use nasal spray in some patients who are not able to take oral metoclopramide or rectal metoclopramide. Continuous infusion can be tried in patients who have refractory nausea, vomiting. It started at a dose of 4 to 5 milligrams an hour up to a dose of 100. We have gone up to 100, but usually at that time the extrapyramidal symptoms start appearing. I would like to say that metoclopramide in the United States has a black box warning for tardive dyskinesia, but our experience is that we hardly see the symptom in most of the patients that we prescribe metoclopramide to. So really the agent of choice in most cases and the first line agent. So you start Mr. MM on metoclopramide, and then you ask him to take ondansetron as needed, and you also start him on a bowel regimen, but he still returns after a few days complaining of nausea. So what do you do now? So I see a question in the chat, is nasal spray available in India? I don't think so, but maybe the Indian physicians can comment. So really, if you've started somebody on first line agent and they continue to have symptoms, there are a few strategies you can try. One is opioid rotation, which we try in some patients and it works. However, the data and the evidence is really limited. Manage refractory constipation, and a constant assessment of bowel movement at every visit is essential. And then really second line agents like olanzapine, which is again our drug of choice now for second line or third line agent. So you increase Senna to 4 tablets twice a day, and then you substitute the ondansetron with olanzapine 5 milligrams as twice a day as needed, and you continue the metoclopramide that the patient was on. So he has relief in 2 days and he has improvement in symptoms. So by combining olanzapine and metoclopramide, again, if you go back to the table, you're targeting multiple receptors and giving this broad spectrum effect. So continuing with his case, you see him again in a couple of months when you're the attending physician on the inpatient palliative care unit or your inpatient unit, where now he's end of life. He is admitted to the acute palliative care unit. He is terminally ill, not able to swallow. He has episodes of agitated delirium and still ongoing nausea and emesis. And so, how would you manage his nausea and emesis now, and what would be your medications of choice? Yeah, so I see some answers on haloperidol, and that's absolutely right. I think the two agents that we still use in our acute palliative care unit, and this is for patients who are at the end of life, prognosis of less than a month or even a few weeks. We use IV metoclopramide and we use IV haloperidol, and they both act as excellent antiemetic agents. So, dopamine antagonists are used preferentially in end of life care situations. They can be given IV and sub-Q. Haldol is a good option because it is less sedating and hypotensive than other antipsychotics like chlorpromazine. And it has a lot of extrapyramidal side effects. So if your patient has Parkinson's or other disorders with extrapyramidal symptoms, then we advise caution. And the other benefit of Haldol is that it can also be used in complete bowel obstruction where you may not be able to use metoclopramide, and we'll talk about that as we go on with the presentation. So you start him on scheduled haloperidol at 2 milligrams every 8 hours. He has relief for nausea, and then he passes peacefully in the palliative care unit. Going on to case 2, so we have Mrs. GG, who's a 48-year-old lady. She has stage 4 metastatic breast cancer. She is on a cisplatin-based chemotherapy regimen, and she comes complaining of nausea and emesis, again not relieved by dose of ondansetron. She rates her nausea really high with occasional vomiting and weight loss, and she has multiple other symptoms associated with nausea that are impacting her quality of life. So what is the etiology of her symptoms? If people can put in the chat box. So, definitely. I see an answer saying chemotherapy, and that's absolutely right. So this is a case of chemotherapy-induced nausea and vomiting. And chemotherapy-induced nausea and vomiting is really related to the type of chemotherapy, first and foremost, that the patient is getting. And as you can see, there is a classification of chemotherapy agents based on their emetic risk. So cisplatin, which our patient was receiving or is receiving, is in the high emetic risk category. So anytime a patient receives a high emetic risk chemotherapy regimen, there are recommendations on using broad spectrum medications for nausea, vomiting. So if you look at how we approach chemotherapy, nausea, vomiting, and there is really good evidence based on high quality trials which recommend really targeting 5-HT3, the NK1 receptors, and then we also use glucocorticoids and olanzapine. So these are the category of medications that we commonly use, and they are sometimes inbuilt with chemotherapy protocols, so patients get medicines concurrent with their infusion of chemotherapy to have relief from acute nausea. So this is the table that is a recommendation from MASC, which is the Multinational Association for Supportive Care in Cancer. And as you see for chemotherapy agents, which are highly emetogenic, a combination of NK1, 5-HT3 antagonists, dexamethasone, metoclopramide, and olanzapine is recommended on day 1. Usually, the same combination is recommended on day 2 and 3, and then the patients can be de-escalated to receive PRN or as needed anti-nausea medications. Again, we recommend metoclopramide really highly in all these patients, but then olanzapine is also quickly becoming another very frequently used medication. So serotonin antagonists are also commonly used in these patients, and we use both first and second generation serotonin antagonists. Advantages are they are available in orally dosing forms. You can dose them Q8, Q12 hours, but they do have side effects, especially constipation and headache, which may be troublesome in patients who have advanced cancer because they're usually on opioids or have delayed gastric emptying and bowel dysmotility, which can actually cause more nausea in these patients. So we see that sometimes when you move these patients from ondansetron to another agent like metoclopramide, we actually have improvement in symptoms. It's also important to remember that these agents can prolong QT interval. So if patients have comorbidities like advanced heart failure, then you have to really be careful on how much you can titrate and how long you can use them. And they are not cost effective. They are expensive, especially the second generation. For people who do not respond to first generation ones, we do try palonosetron, which is used in some patients who are receiving highly emetogenic therapies or stem cell regimens where they have really severe nausea and vomiting. It has a longer half-life and really less chances of QT prolongation. The NK1 receptor antagonists are also increasingly becoming standard of care in most regimens, especially in the US, and there is FDA approval for multiple agents like fosaprepitant and netipetant palonosetron fixed drug combination. They're either given as single day regimen or a 3-day regimen for highly emetic chemotherapy agents. We recommend their use only in highly emetogenic chemotherapy or protocols like stem cell transplant, and their use is really affected by cost and availability. Globally, I'm not sure how the availability of these agents is. So you start Ms. Gigi on 2.5 to 5 milligrams of olanzapine twice a day as needed for nausea and emesis, and at her 1, 3, and 6 month follow-up, her nausea improves significantly, and so does her anorexia, and she's gaining weight. So eventually you transition her to olanzapine 2.5 milligrams nightly to help with her symptoms. So quick word about olanzapine, because I've been talking a lot about it. Again, it's an atypical antipsychotic, but in lower doses has really potent anti-nausea effects. Multiple receptors are targeted. It has also anti-anxiety effects by mild involvement with the GABA receptors. So we actually do find that when we start patients on olanzapine for nausea, they have improvement in anxiety as well. And most of the evidence that we have is in chemotherapy-induced nausea and vomiting, and so as you can see now, it's a standard part of guidelines from MASC and NCCN, which is a large body in the United States. And the current evidence states that it may even be substituted for NK1 receptors, which are receptor antagonists, which are so expensive, and actually might treat breakthrough nausea vomiting better compared to metoclopramide and even ondansetron. So this is a list of evidence that we have for olanzapine and chemotherapy-induced nausea and vomiting, and we have randomized placebo-controlled trials. And then the Korean group compared olanzapine to serotonin antagonists and found more benefit from olanzapine. The uh, dose which was used in most of the clinical trials was between 4 to 10 milligrams or 10 milligrams, but the 10 milligram dose can be very sedating, so we recommend breaking it down to 2.5 to 5 milligrams every 8 hours and limiting the dose to 20 milligrams or less than 20 milligrams a day. Olanzapine is not without side effects, even though it's quickly becoming a miracle drug in palliative care. Most common side effect is drowsiness. Some people have akathisia. So we have had to discontinue olanzapine in some patients, although the number is very small because of akathisia. Some patients may have extrapyramidal reaction. Weight gain is a side effect, but it's actually a positive effect for some patients who do put on weight, although there is still research in its infancy on whether patients are putting on fat or muscle mass. The other serious side effects are in patients who have metabolic disorders like diabetes. It has a low chance of causing QT prolongation, but it still causes QT prolongation in some patients, especially if they're on other medications that may prolong QT interval. And the palliative care population, it may be somebody who's on high doses of methadone for pain management. Increased ammonia level is also reported in some patients, along with elevation of liver enzymes. So we usually, if patients are in the outpatient setting, we usually follow their liver enzymes and then dose olanzapine, or if they have acute liver failure, we usually discontinue and then we'll use Haldol. So this is again evidence of olanzapine, which is also, like you see, showing promise in different etiologies, including use in bowel obstruction, cerebral mets, and then of course in patients with cancer. So moving on to the next case, Mrs. G is a 48-year-old woman with stage 4 non-small cell lung cancer with brain mets, and she comes in with complaints of nausea and vomiting. It's also associated with headache, and she also has new right arm numbness and weakness. For the past 1 week, she's been waking up with a headache and usually has nausea and vomiting early in the morning. So what is the likely etiology of nausea in this case? Yeah, and I see answers coming in already, which is raised intracranial pressure. So that's absolutely right. So the etiology of vomiting in this case is raised intracranial pressure, which is again a very common cause in patients who have either primary or secondary brain tumors. We recommend corticosteroids as the first line therapy, and dexamethasone is usually the corticosteroid of choice. It has a longer duration of action, can be given longer time, less mineralocorticoid activity. In some refractory cases, there is benefit of anti-seizure medicines like carbamazepine, although we do not routinely use it. And advanced cases of hydrocephalus usually need surgical management or management of underlying tumors. So corticosteroids usually work by inhibition of prostaglandin release, decreasing edema, and then they may also change the blood CSF barrier. And they also have other side effects which are very beneficial to patients in the palliative care population, like pain, bowel obstruction, or anorexia. You have to maintain caution in patients who have gastritis, who have peptic ulcer disease, or those who have a history of psychosis, and we recommend very cautious use of corticosteroids in these patients. So usually the dose ranges from 6 to 16, and then usually we say that you see effects pretty early in the first 72 hours, and if there is no benefit of steroids in 4 days, then you have to look at alternative ways of managing raised intracranial pressure. So you start Mrs. G on dexamethasone 4 milligram twice a day, but she still continues to complain of headache and nausea and vomiting. So what has happened here is that we have started her on a low dose. So if the usually we recommend a dose up to 16 milligrams a day. Some of the regimens, especially in hospitalized patients who develop severe symptoms, need IV dexamethasone, and usually we recommend a loading dose of 10 milligrams followed by divided doses of 16 milligrams divided in 4 times a day. And we usually give a trial of 72 hours before we determine if the corticosteroids are effective or not. So I see a question in the chat box saying, do you always co-prescribe PPI with DEXA? We prescribe either a PPI or we prescribe H2 blockers like famotidine. Because we use steroids in very high doses in these patients, they do have side effects of increased gastric acid production. So for the gastroprotective effect, we do recommend, even in the outpatient setting for a course of steroids for 2 to 3 weeks, we recommend adding either an H2 blocker or a PPI. So she has improvement in her headache and nausea, and then the dexamethasone is slowly tapered off in 2 weeks. We recommend slow taper, usually 50% or more reduction or less reduction in about 4 days time. So I see a question, even if the dose is 8 milligrams a day, yes, because usually these patients are going to receive dexamethasone for larger intervals, which is usually a couple of weeks rather than 2 to 3 days. And at that time we do recommend adding an agent. Now if you're giving dexamethasone in the acute palliative care setting, you may not need to co-prescribe a gastroprotective agent, but if your patient is outpatient, then we strongly recommend that you do. So let's move on to the next case. If you remember our patient from the second case, Mrs. GG, she's now back. She started a new regimen of chemoimmunotherapy and she comes back to your office. Since starting next line chemotherapy, she tells you that every time she pulls in the parking ramp and before her chemotherapy infusion, she gets very nauseous. She begins to tremble, she feels like she's going to throw up and is very diaphoretic. And so what would be your diagnosis? So I see some answers in the chat box. So yes, this patient has what we call as anxiety associated nausea vomiting, also called anticipatory nausea, and suggests a cortical component. Usually we recommend behavioral therapy or CBT for such patients, which has shown benefit. Benzodiazepines are used in certain cases, however they are not very good antiemetic agents, and we do not recommend their use as first line agents. We recommend behavioral therapy in such patients. They mostly cause sedation, which works in combination with other agents. Also, if patients are on opioids, then we usually avoid benzodiazepines because they can cause increased respiratory depression in such patients. And we also do not recommend benzodiazepine use in elderly patients for the risk of neurocognitive side effects and also respiratory depression. Coming to case number 5, Ms. JJ is a 50-year-old lady. She has stage 4 ovarian cancer with peritoneal metastatic disease, and she presents to the emergency room, and she has ongoing nausea and emesis. She's having abdominal pain, large volume emesis. It smells of stool. She's worsening abdominal pain, and she's taking her hydromorphone tablets every 3 hours, but her pain is not improving. And this is like a very classic presentation for um, malignant bowel obstruction. So, what is the etiology? What other investigations would you consider? What receptors are involved, and how would you treat that? So, I think this is a patient that needs a very comprehensive evaluation, starting with really imaging of her GI tract. It can be as simple as plain films to a CT scan with contrast to really delineate the type of obstruction she has. As well as the site of obstruction, whether it's a proximal or a distal obstruction, which may actually influence the management. Um, Most commonly, the receptors that are involved are dopamine, acetylcholine, and 5-HT3 receptors. So, really, it's a multidisciplinary management when it comes to treating malignant bowel obstruction, um, both with the medical teams, correction of underlying cause, and the palliative care team. Also, at this point, I think is a very good time to really reassess the prognosis in patients with malignant bowel obstruction and really have those conversations as far as their goals of care are concerned or as far as their prognosis is concerned, because the management and the long-term management really depends on these factors. So non-surgical management usually consists of bowel rest, IV hydration, and then sometimes we have to use decompression using NG tubes, which we recommend for a short duration. And if that doesn't work, then we definitely recommend pharmacological management. So these patients have pain, and the pain is usually uncontrolled, so they may need sub-Q, or they may need continuous IV infusion of medications. We do use opioids in these patients, and we carefully monitor the dose of opioids to give them relief. Anticholinergic agents are also used in malignant bowel obstruction, and so are antidopaminergic. The role of metoclopramide is controversial. The recent guidelines from MASC recommend metoclopramide use in partial bowel obstruction, but we do not use if there is complete bowel obstruction. So you start Miss JJ on a hydromorphone PCA. She's now on bowel rest. She's getting her IV fluids, and then you start haloperidol for nausea. But she continues to have large volume emesis and nausea. And so what do you do next now? So other agents that have been used in malignant bowel obstruction include corticosteroids and antimuscarinic agents. So corticosteroids usually work by decreasing gut wall edema, by relieving some of the pressure, and then also decrease excretion of water into the lumen, and they have a direct effect on the chemoreceptor trigger zone as well. Antimuscarinic agents are used, and we prefer to use something like glycopyrrolate, which has less CNS penetration. They are not the most effective medications for nausea as a single agent, but if used in combination with other agents can provide relief in a malignant bowel obstruction. So you start her on all these medications, but she still continues to have nausea and vomiting, and now she's really having high volume emesis. So what is the next pharmacological treatment that you will consider? So the next treatment, as some people pointed out, is octreotide. And then really the question at this time becomes, when do you consider palliative surgical or GI interventions? So octreotide is recommended in high volume emesis or malignant bowel obstruction, and it works mainly as an anti-secretory agent. We use it sub-Q 3 times a day or every 8 hours, from 50 to 200 micrograms a day. We give a trial of 2 or 3 days to see the effect of octreotide. And usually in patients who have really high output obstructions, or even those with really large secretory tumors, we see a quick response. So this is the study which was placebo controlled and showed improvement in nausea and vomiting with episodes and vomiting when octreotide was compared with a placebo group. And so really the take-home message is that it doesn't have to be the first agent, but if you do not get relief with first-line agents for nausea, vomiting, and bowel rest, IV hydration, if it doesn't resolve, then octreotide is a drug to consider. It is an expensive drug, and that is why we do not recommend it as the first-line agent for malignant bowel obstruction, and we still recommend that you give the first-line agents a try and then move on to this if symptoms are unrelieved. So there is a role of surgical approaches in malignant bowel obstruction, and this is especially in patients who are early in the course of their treatment, have a life expectancy of more than 2 months, have only one site of obstruction which is amenable to either surgical or other endoscopic interventions. If patients have higher comorbidities, advanced age, cannot undergo anesthesia, have multiple different sites of obstruction that cannot be targeted using interventional approaches, we do not recommend that these patients go for surgical or GI evaluation. So usually the approaches that are used in malignant bowel obstruction include gastrostomy or venting tubes, and these provide relief in patients where the role of the tube is just to vent and relieve the site of obstruction. Palliative stenting, both duodenal stenting or colonic stenting, is used in patients and can provide relief. It does come with its own complications, but does give temporary relief to the patients. Coming to some other strategies or other medications that may be used or that are talked about frequently in management of nausea, vomiting, and the first one is cannabinoids. So the evidence of cannabinoids is really limited to chemotherapy-induced nausea, vomiting, and it's not strong evidence. They do have a lot of side effects, including confusion, hypotension, and then in combination with opioids, especially with agents like methadone, they can cause respiratory depression and higher sedation. So if our patients are elderly, if they are on concurrent opioids, we usually do not recommend use of cannabinoids. Not only is the evidence not strong in using cannabinoids, there are multiple legal and regulatory issues, especially in the United States, and they are different based on each state rules. So this is not a treatment approach that is used by our group in most patients. Antihistaminics are another class of medications which are not very strong agents but may potentiate the action of other antiemetic agents. We do not recommend them as first-line agents. They are good agents for vestibular or motion sickness. Dr. Salins gave an excellent review on non-pharmacologic treatments, but some of the ones that we use in our practice include acupuncture, which has some benefit in chemotherapy-induced nausea, vomiting, and then really behavioral techniques to help with other external stimuli which are causing the symptoms of nausea. So this is just a stepwise approach to treating nausea and vomiting, and then the assessment, and really keeping in mind that it's a symptom that is affected by so many external factors. So you really have to go into details and then approach the management. So that brings me to the end of my talk, and thank you very much for listening and participating, and I'm open to taking questions.
There are a few questions. First was regarding the dose of olanzapine. What is
Yeah.
the recommended dose of
Yeah,
olanzapine?
so the dose that has been studied in clinical trials is 10 milligrams a day, or 5 milligrams in two divided doses. We have seen that 10 milligrams can be very sedating. So we recommend you start with 2.5 to 5 milligrams as needed every 8 hours.
Was it, there was another question regarding the use of PPIs with dexamethasone.
Yeah,
So you
I
were
think I already
mentioning,
answered
yeah,
that during my talk.
yeah, yeah.
But we usually do recommend if they are going to be on corticosteroids for more than.
So whichever dose it might be, you will be recommending PPIs,
Sorry?
right? Even with smaller doses like 8 milligram or 4 milligram,
Yes, we
you
do.
will be recommending PPIs. Thank you. There was one question, I think, during Dr. Naveen's presentation regarding haloperidol and the extrapyramidal side effects. Can it cause extrapyramidal side effects?
Extrapyramidal side effects, what we see, which is usually described. Am I audible?
Yes, I.
Yeah.
Yes,
So
yes.
it's usually described in a very larger dose, especially in psychiatry practice. That's why most of the books mention about extrapyramidal. See, we use a very small dose. We start with 0.5 milligram BD to TDS, and some of the patients we give 5 milligrams as a continuous infusion or 5 milligrams in divided dose. I feel that unless they are having Parkinson's, active Parkinson's, or on medications or Parkinsonism features, it seldom causes an extrapyramidal symptom with the dose that what we use for emesis. Uh, I think maybe when we are giving it for delirium, we use a bit of a higher dose than what we give for emesis. And in more organic brain diseases or in psychiatric practice, the dose further goes up. So I feel that in the dose what we use for nausea and vomiting, it seldom causes. I would ask so the other speaker also to give the views.
Yes, I completely agree with you. We have seldom seen extrapyramidal side effects with Haldol, and especially with oral, which is we use usually between 1 to 2 milligrams or not more. We hardly see any extrapyramidal side effects, and usually the doses we use in the acute palliative care unit are higher, but we have still not seen higher prevalence and incidence of extrapyramidal side effects.
Good evening. My question is to Dr. Naveen, sir. I just wanted to know if for a patient who is having Parkinson's disease, who is on levodopa, like on one side, we are trying to increase the dopamine levels in his system. And on the other side, we are trying to, like for nausea and vomiting, or even for example, for delirium, when we use antipsychotics, we are trying to give a dopamine antagonist. So how does this, does this interaction work? That will, which drug levels are affected? Or is there an interaction like that? I was just trying to understand this.
So my take here is to suppose in a palliative care setting, recently we had a patient with Parkinson's on a very high dose of Syndopa and many other medication who was having on and off phenomenon. That means the moment you slightly increase the dose of Syndopa, the person is to get dyskinesias. And moment you slightly reduce the dose of Syndopa, patient is to go into rigidity. Plus, this patient had a delirium because was end of life and had an aspiration pneumonia and sepsis and things like. So in those situations, you really see what is more distressing the patient. If dyskinesias are more distressing, or akinesia is more distressing, or delirium is more distressing, and we have to take one symptom or another symptom as precedence, isn't it? In this patient, eventually we had to use phenobarbital because of the agitated delirium, because haloperidol was causing too much of an issue, and a small dose of phenobarbital was used. Although the role phenobarbital is more of a sedative here as a second line, but you have to take a case by case basis and use your best judgment in each case.
Thank you, sir.
Thank you, Deepak.
Are there any other questions? If there are any questions, you can unmute and ask. Sorry, we are slightly running, slightly delayed in terms of presentation, but if you have time, we can just quickly have a case presentation and discussion, because most of the points are being discussed already. So, but if there is anything else to add on to the presentation, we can. Dr. Kali?
Yes, madam. Ready?
Yeah, we'll
Get the
project it.
slides. Next slide. This is the case. Shall I start?
Yes, sir,
Madam?
please.
Hello. This is a case of 61-year-old male diagnosed as carcinoma of the right buccal mucosa, and he had hyperthyroidism. Next. Next slide. He has pain in the right side of the mouth, maggots in the mouth, foul swelling, orocutaneous fistula, and a persistent vomiting. Next. Patient noticed swelling on the right side of the cheek, and then the swelling at the angle of the mandible, and that was from 21. We have seen the case in 22. He came to us in 22. Patient reported to cancer center where the chemotherapy and radiotherapy. Then patient reported to our center on 17th February 22. Next. Usual examination, nothing specific. General condition was fair, pulse 106, blood pressure 100 by 70, SpO2 98%, pallor plus, NOIC plus. There was an ulcer on the right buccal mucosa and orocutaneous fistula, and maggots were plenty. Next. The treatment and significant investigations. CT was done in September 21, which showed that tumor to 2.7 into 4.5 into 3.2 heterogeneously enhancing tissue lesion, and with buccal mucosa and this superior inferior gingival-buccal sulcus involved, and cervical lymph nodes as usual, 1B, 1A, 1B, 2, 3, and 4. Biopsy was done in October 21, well differentiated carcinoma. Chemotherapy and radiotherapy was done in the same center. Next. Next slide. Psychosocial patient and family had understood the disease and the disease trajectory, and they were aware about the prognosis. So there was not much of an issue in that. Next. The medication, he was on tablet paracetamol, 500 QID, tablet pantoprazole, 40 milligram OD, tablet metrozil 400 for maggots, control and foul smell, tablet. He was on numercazole, 10 milligram BD for hyperthyroidism. The pain increased, so the patient was admitted to start tablet morphine, and we started 10 milligram 4 hourly as the standard dose. What I do, in tablet morphine 10 milligram was increased to 15 milligram because pain did not subside. The patient started continuous vomiting from 4/7/22. The patient was given injection Perinom intramuscular 10 milligram and regular tablets Perinom 10 milligram TDS. Vomiting did not stop. So the tablet, second line, tablet haloperidol 0.5 milligram HS was started, and with usual 15 milligram of tablet morphine was continued. And then so the injection, so we are not happy, and the vomiting continued. So I tried another one, and that is injection dexamethasone 8 milligram OD for 3 consecutive days. And finally the vomiting stopped. Patient was discharged with tablet haloperidol 0.5 TDS. Next. The main concern of what was exact cause of vomiting. Was it a tablet morphine induced, or was it due to oral chemotherapy? And the third one, was it because of the raised, could be there be secondaries in the brain, and that could have caused this vomiting. Next. Summary: a 61-year-old male was admitted as the case of carcinoma of the right buccal mucosa with hyperthyroidism, urothelial fistula. His pain was controlled with tablet morphine, but he had persistent vomiting, which eventually stopped by dexamethasone and haloperidol. Next, thank you. Discussion point: how to handle persistent vomiting, maybe morphine induced or otherwise. Just now we had a long session on this. Thank you.
Thank you, Dr. Kale. I think there is one question to you. Was the patient on oral feed or NG tube? Because everything was given as tablets. So Dr. Punita is asking.
To nasogastric, we crush and give. Here, fistula, all patients of orocrital fistula, we put a rice tube. That is the standard practice in my center.
And Dr. Tendril is suggesting that can it be due to maggots or foul smell?
Yeah, maggot was controlled. It could be. That's what I'm saying. Initially, we thought that, but then with Metrogyl, maggots had disappeared on third day. But the vomiting continued. And then I had a thought whether it could be because we have no means of evaluation by CT brain, whether there was brain mets. Because previous to that, no CT was, the CT was done long back. The brain mets also can cause vomiting. And that's why dexamethasone was with that, so double effect. It can be that as well, otherwise also. So dexamethasone was tried on that, and he ultimately settled with dexamethasone and haloperidol.
Yeah, maybe I'll thank you, Dr. Kale. I'll ask the faculty members about the metronidazole causing nausea. I think so many people are commenting on that, and
Yes,
over to you both.
But madam, metronidazole has to be given in presence of maggot, because otherwise maggots will not be controlled, and that's a prime. But it was controlled after third day. But still, and it is my usual observation. Whenever we put metronidazole oral, the patient will always have nausea, vomiting, and can linger for 2-3 days, even in routine practice.
Thank you, Dr. Kale. Over to Dr. Naveen and Dr. Admin. Because we are running out of time, I'm directly asking the faculty.
Yeah, thank you for this case. Obviously, it is a very complex case, and you have done very well managing this patient's vomiting. I feel that rather than pinpointing to one cause, as Dr. Punita has just chatted it as multifactorial, I would really want to consider as a multifactorial cause. So infection per se in the oral mucosa and in the oropharynx is a strong trigger for vomiting, especially anaerobic infection. So we could dispute metronidazole can cause vomiting, but infection is a stronger trigger, and especially fungal infection more than anaerobic bacteria are a stronger trigger. So sometimes a combination of antifungal, sometimes very difficult to pinpoint a candida which is there along with an anaerobic bacteria infection usually helps. And I felt that the dexamethasone here brought down the vomiting because the inflammation that was there associated with the infection might have subsided along with metronidazole, but probably a more robust management of infection, uh, along with contribution by the drug, which could be morphine induced. And there were two dopamine antagonists used, one metoclopramide and haloperidol, although haloperidol was a much smaller dose. Uh, but so always what we need to think is in terms of a multifactorial cause. And there is one nice table which I read in one of the journal article is about a 10M approach. Whenever there is any nausea and vomiting, look at the 10 M's. Uh, uh, Dr. Sridevi probably knows about it, and I'm happy to share with Dr. Sridevi. It should always think, and we always undermine uh, a multifactorial approach. We always try to focus on one cause. So that's why what Dr. Sonal, when she mentioned about targeting all receptors, is sometimes very useful because of the multifactorial etiology. Dr. Sonal, your views?
I completely agree with you. I think this is a classic case of multifactorial causes of nausea and how really targeting each cause is going to lead to improvement in the symptoms. I think the orocutaneous fistula, the tumor, the inflammation from the infection was definitely driving the exacerbation in the symptoms. And I think especially in the head and neck region where there's such little space and where there's so much inflammation from the tumor, something like dexamethasone acts really beautifully because it just decreases the edema and causes immediate relief. But I think the other agents that were used, especially metoclopramide and haldol, acted centrally and then peripherally, and if there was any contribution from the morphine, I think they really helped with that aspect of nausea too. So I think kudos to the team who managed nausea in such a complex patient.
Thank you, Dr. Admin and Dr. Naveen. Any other questions before we wind up today's session? Any other questions? If you can type it in the chat or you can unmute. I think the last question was answered in both the presentations in terms of management of nausea and vomiting.
Dr. Sridevi, we thank you for the opportunity provided to talk to many of the people who are part of the palliative care management across the country.
Thank you, and thank you for inviting me. And I learned a lot from today's presentation, so this is a win-win situation for me.
I'll definitely share those 10 M's in the WhatsApp group or when we are sending the learning materials, I'll send, I think I still have the presentation that Dr. Naveen used at that time, so I can
I
share
will
that
send that
also.
presentation to you so you
Yeah,
can share it with the
yeah,
audience.
yeah.
Thank you so much, both of you, for the wonderful discussion. And thank you so much, all the participants, for asking questions and interacting through the chat during the case discussions as well as during the presentations. Thank you so much. We have shared a feedback link in the chat. Kindly give your feedback before you leave. And next week, we will have another interesting topic in faculty. Thank you so much, both of you,
Thank
for
you.
interacting.
Okay.
Thank you.
Bye-bye.
Have a good day,
Bye.
everyone.
Bye. Bye.
Bye.